Good morning, Timberline. I'd like to talk with you today about an exciting proposition for all of us to participate in a study. The study is for our cats who have a urethral or urinary tract obstruction. The nickname is TSK UO, standing for Treatment of Severe Hyperkalemia in Cats with Urethral Obstruction. And it's going to take all of us to get this done. It's going to take a long time too. So this is just an introduction into the general thoughts behind the study and then what we will specifically do, but there'll be more training to come at different points so that we all know what we're going to do. Some background. Urethral obstruction, for those of you who don't know, the urethra runs from the bladder to the outside world. And male cats especially can get obstructed due to bladder stones, a clump of crystals, which are all just mineralized phosphorus, ammonium, calcium, things like that. And they could also have an obstruction with an infection. Rarely, but they can get cancer that can cause an obstruction. And then many of our cases don't have any of those things, and it's called idiopathic when there's no obvious cause. And it can be a mucus plug or a spasm that obstructs the flow of urine to the outside world. Why is that a problem? Well, when you can't urinate, you can't get rid of the kidney toxins. We measure them as BUN and creatinine. And you also can't get rid of electrolytes and other things that go out in the urine. And the most scary one is potassium, whose symbol is K, hence the K of TSK UO. And high potassium is called hyperkalemia. Severe hyperkalemia, that is life-threatening, only happens in about 10% of UO cats presenting to the hospital. 90% have either not that bad an increase or no increase at all, even if they might have increases in the BUN and creatinine. So what is the problem with hyperkalemia? Well, the extra potassium in your bloodstream that can't make it out in your urine will affect your muscle and its ability to contract and form electrical signals. And the most important muscle in your body is your heart. And so the potassium has a lot of effects on the heart and conduction. And it'll basically take a normal electrical beat and turn it into the very bottom pattern, which is a sine wave if it gets really high. And you can see the progression. Normal potassium is about less than 5. And here you go 6 to 7, 7 to 8, 8 to 9, and greater than 9. And you can go into ventricular fibrillation. The first thing that usually changes is you lose your P wave here, as you can see. That's one of the first things. And then the T wave gets really tall. And then the QRS and the T begin to slur together so that they became just a single wave. Many times that can be confused with ventricular tachycardia, and some people will want to give lidocaine if they see it. But this is a problem with an electrolyte, and if you can fix that, they'll get better. But if it continues without being treated, that can lead to death. So what do we do to fix the potassium? Well, we know that as if you need to get rid of potassium, we can fix that. We can place a urinary catheter, and then your body can start to put out the potassium. So we unblock them since they are blocked. And then we treat with fluids, and that will help flush the kidneys and get rid of the potassium as well. And there are studies that show that cats that receive fluids do better than cats who are just unblocked. Those are studies from back in the 70s. And then the best thing you can do for the heart is to counteract the effect of the potassium with calcium. And that stabilizes the heart, but it does not help you get rid of any potassium. What other options do we have? Well, there are drugs who help you hide the potassium until it can be lost in the urine. And what that means by hiding is that you move it from the bloodstream to your cells. So inside your cells is actually a very high potassium state. Inside the bloodstream and the extracellular fluid, that is all a very high sodium fluid. So moving it into the cells is not dangerous. It's just hiding it for a little bit. So there are a couple of therapies that can do that. You may have heard of insulin. So insulin, it works pretty quickly by way of its receptor to increase potassium pumping into the cells. So you can see the insulin receptor, and here's the sodium potassium pump. So potassium will move into the cell more with activation by insulin. And that lasts about 2 hours, sometimes longer, and can be used as a bolus or a CRI, depending on how you use it. And then what the problem with that is if your glucose level, your blood sugar is normal, then the insulin will cause you to have low blood sugar, which is dangerous. So you also usually pair that with dextrose. So you give insulin and you also give extra sugar by dextrose bolus or infusion. And that will help keep you maybe from getting hypoglycemic. The problem is that studies have shown that cats on insulin and dextrose, no matter if they get a dextrose CRI, a lot of them become hypoglycemic. So there's some complications with that extra therapy. So you're giving something to help them, but you may also be hurting them. There is no evidence that if you use the sugar alone and hope that your own body's insulin will push the insulin in and then cause these changes with your sodium potassium pump. There's no evidence in humans that that actually works. So this therapy is a no-no. And what about albuterol? So there are also beta 2 receptors on these cells that, if activated, will also cause the potassium to go into the cell. And previously, bicarbonate has been used as a sodium bicarbonate injection, will change your acid-base parameters and then force potassium into the cells as well. But in human medicine, no one does that as a standalone. That is done when you're also doing insulin, dextrose, or albuterol, or all of them. So it's an additional therapy. So no one really knows that that's that helpful. So we know that we have multiple options to treat these cats, but what is the best treatment? Well, we're going to compare just fluids, standard treatment, that's what we would consider standard treatment, fluids and unblocking, with insulin and dextrose. And so we're going to try to see, does the potassium decline differently for one group versus the other, or are they the same? And then how many complications do we actually see on the protocol? We're going to have a standardized insulin and dextrose dose. How much hypoglycemia do we see? And then we're going to try to see where this potassium goes. So we're not only going to measure potassium in the bloodstream, we're going to measure potassium in the urine, in the urinary catheter. My belief is that there is no significant advantage to using insulin and dextrose to just unblocking and putting on IV fluids. And other people may not agree with that. So we're going to find out the answer. So how do you become a subject for our study? Well, you're a male cat and you have signs of urinary tract obstruction, the non-expressible bladder, the painful urination, the straining, etc. A lot of these guys are also presenting for vomiting because they're sick, so that may be one of their triage parameters. For this study, they must have severe hyperkalemia, and that's greater and equal to 7, and that's been hypothesized as severe or standardized as severe for a couple of studies. So that's what we're going to choose. They cannot have a history of chronic kidney disease, acute kidney injury, like they were a lily cat at some point, and they can't be on any medications that could affect the way the kidneys work. So steroids, ACE inhibitors like enalapril or benazepril. They can't be on furosemide or any of those things. And they cannot receive a decompressive cystocentesis. So some people, including our regular vets, will use a decompressive cysto to remove some urine before they send them over. The problem is that puts some urine in the abdomen potentially, which would mess up where is the potassium going. So we don't want to do that for our cases. And then the most important thing about picking these patients is that the client has to agree to let their cat be in the study. Now, hopefully, they will want to firstly help the knowledge base to treat these kitties, but also secondly, we're going to try to make it so that they get something out of this financially. So what does this study look like? So at presentation, we're going to find out on EPOC if they qualify for the study or not. We're going to get owner consent and get a catheter and start the cat on fluids. Now, some people aren't sure when they want to start fluids. That's okay, but the cat has to be on IV fluids by the time they are going to be anesthetized. Then the study period starts. Time 0 is when the cat is unblocked, and then the study starts and goes for 12 hours. So at time 0, we're going to collect our urine from the urinary catheter after the catheter is placed. We're going to divide that urine into a sample for urine electrolytes that's going to go in the fridge separately. And we're going to send out our standard urinalysis to IDEXX. If you want to do it in-house, that's fine, but it is much easier to get it standardized and go out. And we're going to put our patient on the EKG if they haven't already been on the EKG. Most of the time with severe hyperkalemia, they're on an EKG to start. After they're unblocked, we're going to get our x-ray. And during this time, at some point, probably before they're unblocked, you're going to know what treatment group they're in, because you're going to start that treatment group treatments, and I'll open Instinct, who will have a specific treatment group for each of the treatment groups, the standard group and the insulin dextrose group. So during this study period time of the 12 hours, our job is to on time get specific data. And the data is the same at each 4-hour interval. So at time 4, we're going to run another EPOC. We're going to get urine from the line to collect for electrolytes and put it in the fridge. Because we're not measuring that right now, we're going to send that out for later. And you're going to look on an EKG and make sure you know what rhythm is happening. Then you're going to do it again at 8 hours. And then the final time point is at 12 hours. And after 12 hours, they're out of the study. So whatever treatments go on from there are up to the vet in charge. So just to summarize, this is a 12-hour time period, and the clock starts at unblocking. That is time 0. You will already know that the pet has a high potassium, and you will already be starting with catheter and fluids, but time 0 is when that patient is unblocked and starts their treatments. So these things all have to happen at time 0. You want to have your treatments ready, your fluids ready, everything going. So what we hope to produce is this kind of chart. Here are our time points, 0, 4, 8, and 12 hours after unblocking. Here's the potassium concentration on the y-axis. And then there's a pink line and a yellow line, and they appear to be different. The pink seems to be doing a better job getting the potassium down than the orange line. I don't know if those lines will be different or the same, or which one will be which. We would like to have 18 cats in each treatment group. And at the rate that we see severe increases in potassium for these cats, it's probably going to take us 1.5 to 2 years to get 36 total cats. So hopefully we get 1 a week, 1 every other week, and we can get pretty well situated in how we do this study. So let's talk about that a little bit. Oh, I forgot. Why are we collecting urine samples? Why do we care? So one of the things about this is we think that all those treatments are sending potassium into the cells, but we don't know those extra treatments, the insulin and dextrose. So what we want to see is, where does the potassium really seem to go? And no one's looked at urine electrolytes in these guys. So here's your kidney, there's your glomerulus, and urine comes out, tubules, and here's where potassium secretion happens at these two spots. So we want to know how much is coming out, and is there any effect of fluids or the rate of loss, any of those things. So we're adding that as a factor. Now, how do you know potassium, if one of them's having post-obstructive diuresis and they're making a lot of urine? Well, you always compare potassium in the urine to creatinine in the urine, just like you might do a urine protein creatinine ratio or a urine cortisol creatinine ratio. Creatinine is sort of always excreted at about the same rate, so it's a good constant. Okay, so what is the most important thing for success in this study? Keeping time with your time 0, 4, 8, and 12, and then labeling all the tubes, labeling your epochs, making sure they all load, everything has the patient's name. A helpful thing for that is to use timers, and we'll have special timers for this, as well as special reminders. So let's talk about how we're going to do this, right? The patient comes in, we've identified they're a block cat. We're going to get an epoch as soon as possible, so we can say, yes, the potassium is greater or equal than 7, or no, they're not that sick. And once we know it's greater or equal to 7, we're going to talk to the client about your urinary tract obstruction in general, and then possibly being in this study. You will then open your packet. And your study packet will give you instructions as well as give you a consent form. And here is the consent form. This is the top of it, and then the back side is where they sign. Very, very important that they sign that, and it has their name, and that they give consent. Now the packet will be in the cabinet, file cabinet by the doctor's desk. There'll be a number of packets that are sealed in there. And here's my subject going and getting her packet. And in the packet, it's going to tell you, number 1, did you make sure that you were a good candidate for the study? And then number 2, it's going to tell you what treatment group you're in. Are you in the control or the insulin dextrose? So let's look at that. Assigned group control, that's what comes out of the packet. Assigned group insulin dextrose, that's what comes out of the packet. And then you'll have signing areas here where you're going to initial all the different things. This is what you should be getting in your packet. You're going to get the checklist, which is this, consent form, the urine tubes pre-labeled with the collection time, a cage clipboard with a checklist, and a timer. So that's when the study instructions are given to you. So here is Heather with her checklist on the clipboard and her multiple tubes that are labeled, which can be then just kept right on the cage until they're used. And then this tells you what to do for each of the cases and what to keep track of, and then you can check them off as you go, including letting me know that a patient has been let into the study. Now, really important that we collect urine from the line and not from the bag. And all you need is a couple mils that will go into your labeled tube. The line represents the most current urine from that patient. So you get it from the bag, that's pooled for over the last 4 hours. I need to know the most up-to-date, up to the moment urine. So you're going to collect from the port from the line. So if you go back to this, right, we're going to have, they present, then they're going to start the study. So the instinct starter groups will have prompts for every time point, as well as your clipboard. And then the EKG will be on the patient the whole time. Hopefully then you can keep track each hour and compare. We'll have some laminated cards for different ways that the EKG could look. And that's it. If we do it right, we'll get all of our patients, and then we'll be able to say what the best treatment is. And I really appreciate all of you. I think this is going to be really exciting, and you're all going to be part of a fantastic, successful, private practice randomized study. Thank you very much.